Good morning. Hello, this is Hans Friberg, Lund University, Sweden. My topic today is TTM, let's wait and see. And these are my conflicts of interest. The objectives of today's talk is to argue for wait and see. And in practice, this means that we should stay at 36 degrees Celsius post-arrest until the results from the TTM2 trial are available. With regards to TTM after cardiac arrest, it's important to understand and know the normal body temperature. And of course, we need to investigate and find the optimal temperature for post-cardiac arrest care. Current guidelines recommend a range of 32 to 36 degrees Celsius. And now we will soon have the results from the TTM2 trial, and I suggest we wait for them until we change anything. So what about the optimal temperature during homeostasis? There is a recent study published in the British Medical Journal that investigated 35,000 individuals, more than 240,000 measurements, and they found significant individual differences in normal body temperature. And the mean temperature in healthy people was 36.6 degrees Celsius, with a 99% range of 35.3 to 37.7. So the upper limit of normal body temperature is thus 37.7 degrees Celsius, which translates into fever, definition of fever being above that number, 37.8 or higher. And this is something we used as a definition in the TTM2 trial. What about the optimal temperature during stress or after injury? Well, we really don't know. So in search for the optimal temperature, the optimal TTM post-cardiac arrest in humans, we have several options to investigate. Deeper TTM, that is a lower temperature, a prolonged TTM, that is TTM for a longer period of time, or the combination of the two. We could and possibly should look into the timing of TTM. Personally, I'm very fond of that. I believe it's important. And some colleagues stress that there is not one solution for every patient, but that we should pursue individualized care. But the overall important question, as I see it, is still that to answer the question whether TTM after cardiac arrest matters at all. I would like to present a recent randomized trial from a French group where they randomized 581 patients with non-shockable rhythms to either 33 degrees Celsius or 37 degrees Celsius. These patients had asystole, 80% of them. In 10%, they had PEA as the initial rhythm, and in 10%, the initial rhythm was unknown, non-shockable, which is an interesting and important fact. And that may have introduced bias in the trial since the numbers differed between the two intervention arms. 73% had an out-of-hospital cardiac arrest, whereas 27% had an in-hospital cardiac arrest in the trial. Primary outcome was CPC 1 and 2 at 90 days, and the results favored TTM at 33 degrees with an absolute difference of 4.5%, with rather wide confidence intervals, and with a p-value of 0.04. Mortality did not differ. I would like to draw your attention to a figure in the supplementary material that I find is very interesting. It's a subgroup analysis, and what you see is a forest plot. And in this subgroup here, they have dichotomized time to ROSC as either below 15 or above 15 minutes. And it's clearly shown that the subgroup where hypothermia, where TTM 33 was favored, was in the subgroup with shorter times to ROSC. And in the subgroups of in-hospital versus out-of-hospital cardiac arrest, the subgroup with the in-hospital cardiac arrest was also favored the hypothermia intervention. So TTM at 33 was associated with improved outcome in patients with a less severe injury, which I find quite interesting and somewhat surprising. Let's go to the TTM2 trial, where we investigate hypothermia compared to or versus early treatment of fever. And I would like to introduce two important persons in this trial, Joseph Dankiewicz and Helena Levin. In this phase 3 randomized controlled trial, our hypothesis was that rapid cooling to 33 Celsius improves survival and neurological outcome compared to normothermia and early treatment of fever in unconscious adult patients with out-of-hospital cardiac arrest of a presumed cardiac cause. The design was to randomize to either rapid cooling to 33 or a group with allowing a temperature up to 37.7. Patients who reached 37.8 were intervened with lowering of temperature to a set degree of 37.5. The intervention period was 40 hours in both arms. Primary outcome in the TTM2 trial is 6-month mortality, and secondary outcomes include modified ranking scale. We also look at 24-month neurocognitive outcome in this trial. So to give you an update on the TTM2 trial, the first patient was included in November 2017, and the last patient was included in January this year. The last follow-up of primary outcome mortality was thus performed in July 2020, and the results will be presented in March of 2021. This trial was funded by Swedish research institutions. And here's the graph of the inclusion rate in the trial at 61 sites in 14 countries. And as you see, there was a nice and steady state intervention rate of 3.9 patients per day during the steady state period of the study. And TTM inclusions by country show that Sweden and UK included most patients, followed by Switzerland, France, Czech Republic, and Norway. Among these 1,900 patients, what could we expect to find based on the TTM1 trial? Well, we will probably find a similar age and sex distribution in the TTM2 trial. We will possibly find that we have a higher proportion of non-shockable rhythms in the TTM2 trial for different reasons. We will probably find that we have a higher proportion of patients in shock, since cardiogenic shock was not an exclusion criteria in the TTM2 trial. Further, looking at potential results of the TTM2 trial, if there is a benefit of 33 in the TTM2 trial, which we don't know, this would probably mean that many sites will move to 33 as a standard TTM strategy, and that the next trial should include a duration trial where we look at an optimal dose of TTM, for example, 24 to 48 hours of TTM post-cardiac arrest. If, however, the trial shows a benefit of strict normothermia, or if it's clearly neutral, in that case, I believe that most will abolish 33 as an intervention and instead stay at 36 or just preventing fever. And in this case, in the next trial, we should investigate the role of fever. And personally, I think that we should investigate ultra early hypothermia versus normal care in dedicated centers. So in conclusion, with regards to TTM post-cardiac arrest, I suggest we wait and see. And in the meantime, we should stay with TTM 36 degrees Celsius or stay with this TTM strategy that you are comfortable with in your site. And with that, I finish my talk, and I thank you for the attention.